Hi, and welcome to Parkinson's Concierge webinar. Tonight's webinar, Living with Parkinson's and Sleep Issues. And along with that, we're very pleased to have the three distinguished guests on our panel this evening. Before we go ahead and introduce them, I would just like to read out a couple of notes, and I hope you understand. These are very challenging times for us all, with the continued regional lockdowns, the countrywide lockdown, uncertainty about effects on businesses and jobs, restriction of activities, all the social distancing rules, etc., is likely to cause a lot of anxiety and stress, with more reliance on charities wherever possible. That, in turn, has a tremendous reliance on the funds that are available for the charities. As we know, the lockdown period has significantly affected those of us who have planned fundraising activities, running marathons, cycling events, walks, for example, and most of the major contributions to charities come from these events. Therefore, it's important to remember that this has a huge effect on the charities who rely on these funds to provide the ongoing services for us all. I therefore ask you to kindly consider offering a donation to our charity of the month, which is the EPDA, European Parkinson's Disease Association. And that will enable the charity to continue its offering of the essential services that we all take for granted as being there. There will be a link in the description for the EPDA, as well as on the questions feed. Right, without any further ado, Parkinson's Concierge hope that you respect our rules when engaging with medical professionals and academia, that we are not able to discuss any specific medication. The reasons why we've brought this expert panel together is for the benefit of the Parkinson's community as a whole, to help understand what causes sleep issues, and in turn, what changes can be made to their lifestyle, and share recommendations of the do's and don'ts to improve your sleep health and in turn improve your quality of life. Right, if I may, I'd like to introduce our three guests for this evening's question and answer session. And we aim to have that light and informal. And if we don't answer all of your questions, please bear with us because there is a fair bit to get through. We've had a lot of response to the questions that we've asked the community for in advance. So if we don't get around to asking your question, we'll do our utmost to get an answer for you. Right, we are pleased to welcome Mr. Gennaro Pagano. He's a physician, neuroscientist, and Pharma medical director with 10 years of translational research in academia and early clinical development, leading early clinical development of programs in Parkinson's disease, Alzheimer's disease, sleep, and other common and rare disorders. And he joins us on our panel tonight all the way from Switzerland. Welcome, Gennaro. Our next guest, who is someone who has been on one of our previous webinars, is Dr. Amit Batla. He's a movement disorders neurologist. He works as an honorary consultant at National Hospital for Neurology and Neurosurgery, Queen Square, and he's also a consultant at Luton and Dunstable University Hospital. Dr. Batla joins us from the UK. Welcome. Our third and final panelist for this evening's session is Julia Worrell, the sleep RN consultant. A critical care nurse with 25 years, as well as the educational director for the Foundation of Airway Health. Julia has presented her findings on an international level and continues to push for more comprehensive sleep programs for first responders and the public in general. And if I'm right, Julia joins us from Canada. Welcome to the guests. One other topic I'd like to mention is that tonight's webinar has kindly been sponsored by Opera Health, who because it's sleep issues, they make accessible beds. So we, putting them two together, and hopefully they are trusted experts in care for beds and mattresses. Right. Questions in no particular order. Firstly, before we go to the questions, can I get you, Gennaro, please, to tell us a little bit more or anything I've missed out?
Sure. Thank you first of all of the invitation, and it's a pleasure to speak about Parkinson, in particular about sleep. It's been part of my academic research. And to tell a bit more about myself, I'm a movement disorder specialist. I trained between Italy and US, and I mostly work in London, first at Imperial College and then later at King's College. So, and my research has been focused on trying to understand the key driver of the symptom of Parkinson. One of them is sleep. And I use different tools from fluid biomarkers to what is called imaging biomarkers, MRI, molecular imaging, PET, SPECT, that are able to measure the biological function within the brain. And I use this tool in different stages of the disease, in particular for people with sleep problems. And I also participate and led several clinical trials in which I tried to repurpose drug, particularly for sleep and another indication for Parkinson. But then I quickly realized that was not that simple. So in the last years, I joined the industry. I joined Roche because here I have the opportunity to combine together diagnostic tools with the possibility to design new drugs tailored on the patients. And I come from an understanding, follow my patient in the clinic, that each individual is different. And through the study that I've done, I clearly demonstrated that it's very complicated to say what is the cause of Parkinson for everyone, right? It could be many different causes, and there could be many different causes of sleep and also progression of the disease. So I think we will touch through the question, the detail. I can tell you I work across different sleep dysfunction, and mostly there are several pathways involved, from the dopaminergic, the common one, to serotonergic, but also other pathway associated with inflammation, with the involvement of the so-called astroglia, is a specific cell type in the brain. And but mostly what I found is that patients with sleep problems, in a way or another, progress faster once they have Parkinson. And it's not only true in the early stage of the disease. There are many studies on that, right? That you see that there are this onset of symptoms early. It's also possible that sleep problems have an onset later in the course of the disease because it's heterogeneous. And some of the biomarkers that I work on, for example, the alpha-synuclein markers or the imaging, the aspect, are predictor of progression. So they are associated with faster progression, mostly when patients have problem with sleep, in particular a typical sleep problems called REM behavior disorder. I think we will have the time during the conversation to touch that. So I'll leave other colleagues.
Thank you so much, Gennaro. It's a pleasure to welcome you to tonight's webinar, and I'm sure that it'll be as much enjoyable for the viewers as it is for us to have you. Dr. Batla, can I ask you to introduce yourself a little bit more, please?
So I'm a neurologist. I see patients. That's my role. So what I do is I do movement disorders clinics at Queen Square, at Royal Free London, and Luton Dunstable Hospital. So as part of the practice, of course, I specialize in Parkinson's disease and movement disorders. So I often hear problems with Parkinson's and sleep disorders, as you can imagine, and that's why this involvement. I'm also interested from the research perspective on the circadian dysfunction in Parkinson's, and we're doing a few studies related to how the biological clock that regulates sleep and wake cycles in human beings is the cause of problems, a lot of the sleep problems in Parkinson's, not all of them, but some of them. And so that's what brings me here.
Fantastic. Thank you so much. And it's a pleasure on behalf of Parkinson's Concierge and the viewers to welcome you tonight. Thank you so much. If I may now go across to Julia, who's been sat up there in the corner old patient. If you'd like to introduce yourself a little bit more, please.
Sure. So I'm Julia Worrell. I'm a registered nurse, and I've spent the majority of my career in the emergency department in ICU. And I look at the body from a very mechanical point of view. So what I've discovered in my career is that even if I couldn't understand the language someone was speaking, or they were intubated, we could still tell a lot about what was happening with the person. And I became fascinated with how the face speaks to us and tells us what's going on in the body. And so looking at the neurological pathway of the face to the brain to the body through the vagus nerve. And when you take Parkinson's, you know, what we see years before is issues with the gut. So that gut-brain connection, and how can we heal that? How can we get the gut to be functioning properly to produce an appropriate amount of dopamine? I speak about the tongue. What we see as a disturbance in gait that starts to evolve is if our tongue is not communicating appropriately with our brain. And that whole deep front line from our tongue down to our toes, if that begins to weaken, the diaphragm begins to weaken, we get the stooped gait, we get the shortened posture. All of these things to me are very mechanical. And when we start to correct some of these mechanical issues, what we could see is a reduction in symptoms, Parkinsonian symptoms and tremors and neurological function, mood elevates, those types of things. So I come at it from a very mechanical point of view.
Fantastic. And thank you so much for your time and for agreeing to join us on tonight's panel. So if we may go across to the questions, and they're not in any particular order other than we've went through the questions and we've put them for the most appropriate panelist that we feel. But if any of our other guests would like to answer or have a view on that as well, by all means, it's informal and relaxed. So the first question, and for the purpose of this going out recorded, I must say that I'm not going to mention the patient's name. I'll just go straight onto the question. So the first question that I'd like to ask is for this going out recorded. Oh, sorry, I don't know what happened there. Boom, 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 boom. Is it true that sleep issues occur in over 96% of people with Parkinson's? And I'll address that one to Dr. Amit Batla, please.
Yes, I think the figures and the numbers vary a lot. So in clinical practice, it depends on what stage of Parkinson's we're seeing the person in. So for example, early stage of Parkinson's, the sleep disorders might be 50% or so. But as the disease progresses, I think this figure of 96 or 98% comes from a scientific study that was done. And this is sort of a few years ago. But this was over the course of Parkinson's. And that is very difficult to quantify, isn't it? Because some people have a course of Parkinson's of 50 years or 60 years as well. So I think it's a bit difficult to assume that if you have Parkinson's, you will have a sleep disorder 98% of the times. You can't derive that because that was the implication I got from this question. So overall prevalence of sleep disorders, in early Parkinson's is around half of them. And as the time goes on, it's almost 2/3. That would be the figures that I would realistically believe in. But obviously, it depends on how you define the sleep disorder or what problems. So because I think this figure from 98%, the paper mentioned nocturnal problems, meaning problems at night, which is different from sleep disorders or sleep problems. So I think it's good to have that clarity that, of course, people will have a disturbed night with Parkinson's. Does that necessarily mean they have sleep problems or not is a bit subjective. So it's good to understand that. But I think, as I said, half of them at the beginning, 2/3 later is a better figure to understand.
Fantastic. And thanks for being so thorough. I do understand what you mean with regards to nocturnal, because that could include a host of other issues, such as getting up to go to the toilet frequently, which is entirely different to a sleep issue. So thank you for answering that. If I may come to you, Julia, what complementary therapies are available to help good sleep health?
So there's a number of things, because one of the major things that you see in Parkinson's and movement disorders is this lack of communication with the brain. So if I show this image here, and you see in the skull, there's this little spot here on the roof of our mouth that loves to get input from our tongue, and is connected through our deep front line down to our toes. So this fascia that is a continuous, here's our tongue up at the very top, you can see our tongue, and then it goes all the way down to our toes. So that is what helps to communicate to this spot in our roof of our palate to our brain as to our gait and our position. The other issue with our tongue, though, is that if our tongue is sitting low and not sitting up there, our tongue could be sitting in the back of our throat, occluding our airway, which becomes a problem when you go to sleep at night and everything relaxes. You can have some obstructions occurring and a drop in your oxygen, which your brain then will cause an arousal to occur. And that could jar somebody out of their sleep, create agitation and a difficulty in settling afterwards. But to tag team to the previous comment, for example, somebody getting up to go pee several times during the night, you know, the heart and the kidneys are best friends and they help each other. So technically, we shouldn't be getting up to go pee several times during the night, right? That's a sign that there's something happening during our sleep, that our heart is getting overloaded and needs our kidneys to take some fluid off to reduce the workload on our heart. So it all comes full circle. You know, we're talking about the tongue and it seems like a little organ, but it communicates so much and it can be responsible for so much of what might be happening during sleep. So oral myology, speech language pathology are fantastic for working with that. In addition, getting the tongue up into that spot means we cannot mouth breathe. We have to breathe through our nose. So helping our patients to retrain their breathing. A lot of people with Parkinson's mouth breathe, and that changes and puts them in the sympathetically activated state. So in order to help their brain, we got to get them to nasal breathe only, slowly, deeply, diaphragmatically, strengthening and toning the diaphragm, which in exchange is going to help to raise the rib cage, correct any forward head posture that might be going on that also impacts the flow of their cerebrospinal fluid, etc. So really looking at the breath retraining, tongue positioning, and helping correct posture and gait. And these types of things help to improve and give somebody the best neurological state that they can achieve given their situation.
Fantastic. Thank you so much. And thanks for having the slides to present. Very interesting. Gennaro, Amit, do you have any answers on to help getting good sleep health?
I can say a few things, yes. I think one of the key things that we often forget these days is that we've got devices all around us and we've got light from the screen that disturbs sleep. So that's important to keep in mind, especially the blue light keeps people awake. So it's important to have what we call as a sleep hygiene, meaning no screens when you're trying to sleep. It's very tempting to get up and look at your phone when you wake up to do some sort of, for example, if you went for a pee, it's very easy to get caught up looking at your screens and not go back to sleep. So that's another bad sleep habit. The other sleep habits that I often discuss with patients in the clinics, it's individualized, of course, everybody's got a different routine, but having a good pillow, having a comfortable position of the head. A lot of the times people with Parkinson's can have an off period at night, meaning the medication that they're getting is not enough for the night. So again, these are some other measures that you can consider in helping improve the sleep. But having a good time to sort of fixed time to go to bed and get up in the morning is always very useful. So just simple things that your mom would tell you, but it's difficult to practice. But it's useful, I think, for improving sleep in Parkinson's as well.
Fantastic. Thank you very much. Gennaro, would you like to come in on this one?
Yeah, I mean, I think it's also specific based on which sleep problems you have. So if you think about mostly insomnia or problem to fall asleep, my suggestion would be following what's already said, but also looking at trying to restore a circadian rhythm that could be normal, right? Most of the people with Parkinson, sometimes they trying to be driven, right? They can reach out, they want to reach out something, and you work on is your work maybe that you have to work at night. For example, I found this very common in many of my patients. So what I suggest, if you can, based on your schedule, try to have a routine in which you fall asleep roughly, try to fall asleep roughly at the same time. You don't have like watching television and falling asleep while you're watching, right? This is active. So I would say try to have a hygiene, as was said before, but maybe also look at light. One of something that we don't consider. One of the key driver of our wake up, our alertness is the light. So what I always suggest to my patient to try to look where they sleep, to look at what is the structure of the room, try to have maybe something to cover their eyes. And this helps. I found that this could have an effect. And also exercise, is another thing that is really, really, really important. Seems strange because you get fatigued with exercise. I suggest to do mostly in the morning and not close to sleep. So these are some suggestions I can add. I mean, it's hard to be the last one, but I tried.
That's fantastic. Some very good indicators and some points on there. Thank you very much. If I may stay with you, there's a question come in here. Please, can you explain what REM sleep disorder is?
To me, stay with me.
If possible, yeah, please.
I mean, there are several sleep disorders, we said, right? One of the most common, at least in the last years, has been defined as REM behavior disorder. So REM is one of the stages of sleep. If we want to summarize, we go through mainly 5 stages of sleep. Some of them are sleep phase in which we are able to move a bit, right? And are slightly, first are light, stage 1 and 2, and then became deeper. These are very important for the brain to get restored. And then we have another stage of the sleep in which we should be able to be completely solid, stiff, and not move at all. And this is the REM behavior, the REM sleep. And some people, unfortunately, are not able to be stiff or have atonia. It's called atonia. Like you don't move yourself during that period. So in some cases, this is a disorder. So it's or in other cases is kind of idiopathic. So there is no cause. But in other cases, can be secondary to Parkinson or could be secondary to specific medication that people are taking. So first of all, I suggest to this disorder that is basically the incapacity to be in atonia. So you acting out during sleep, you move your hands, you maybe scream. Maybe there are other cases in which it's more violent. In some cases, people can also get injured. It's very important to have a proper diagnosis. And then if it's in the context of Parkinson, it's really important to try to do whatever is possible to improve your symptoms. In some cases, can also be associated with the progression of the disease. It's not starting at the beginning with increasing of the drugs, for example. So that are taken to improve the motor symptoms, but might make the sleep worse. So it's very important to follow holistically all the aspects.
Fantastic. Thank you very much. Does anyone want to come in on that question? We'll move on to the next one then. Thank you so much. My husband with Parkinson's wakes me up in the night to get out of bed. Some sleep problems affect the whole family. And if I can address that one to Dr. Amit to start with, please. So
sorry, I didn't get the question as such. I think this is so somebody is having a problem because of the disturbance due to somebody, so a partner and a bed partner.
That's right, yeah.
Problem. So this is very common. So bed partners' sleep is affected. We've actually some data on the carers and the partners. Their sleep is almost as as disturbed as the person with Parkinson's. So
Right.
every time when you share a bed, and I've had several instances of patients telling me that they sleep in different rooms, particularly because of the REM sleep behavior disorder and the risk of injuries and everything else. But it's very common to disturb the sleep of the partners. What can you do about it? So I've had solutions from the patients rather than give them the solutions most of the times. So they will often tell me that they build a wall of pillows between the two. They would often have a larger bed, for example, so that they don't wake up. They will instruct the partners not to turn on the lights when they get up. They can only have, some people have motion sensor lights at night, so that leads them to the toilet rather than waking up the partner. And simple things, I think, again, simple logic, no medical advice on that. But if there was anything that I missed in this question, do let me know, Ras. I think I said what I can.
That's fantastic. Yep, really good. Anybody else like to pop in on that?
Yeah, so, I go to some nursing interventions that can make it a bit easier. So maybe a commode or a urinal closer to the bed so the person can be a little bit more independent in voiding. Some positional therapy, there's pillows out there that have a nice thick bolster, but keep the patient on their side. So if they're waking up because of airway issues, that might help. The light, yes, keep the lights low and down low to the ground, but definitely no overhead lights. If they have a bed, like the sponsors here sell, but if they can elevate the head of the bed 30 degrees, that helps, with some of the sleep and airway issues, some difficulty swallowing their secretions. A glass of water beside the bed in case they're having dry mouth and waking up during the night. So whatever you can do to address the issues that person is having and get their sleep resolved is going to obviously help the caregiver. But the caregiver is still going to suffer from a secondhand sleep disorder because they're hyper aware. It's like a mom with a new baby. You can't ever let yourself go to just have a good solid sleep because you're constantly worried about the other person. So, addressing your own sleep issues, helping the other person. I did want to mention too about for the person with Parkinson's, that relationship between the gut and the brain. What we see is huge disparity in vitamin D levels. So when you're looking at helping the person fall asleep within their circadian clock, you have to look at the vitamin D levels, and they have to get up to a therapeutic level of, a therapeutic level, I will say. I'll let you discuss with your doctor what that is, but up, because that is going to make it so the patient can't help but fall asleep around 10 p.m. and sleep through to 7 a.m. in the morning, and decreases the amount of REM disorders that they have. And it really helps to kind of reset their circadian clock. And while we're working with patients and getting those vitamin D levels up, what we find is they start sleeping more during the day. They start catching up on lost sleep. So that is a critical part of helping somebody to restore their sleep and get into a natural circadian rhythm that they may have lost, because particularly with Parkinson's patients, their vitamin D is going to be low. So we kind of bring all of these things together and help the family in general to optimize their sleep.
If I can echo what Julia said, one second-hand disease, sleep disorder, could be linked also to pets. It seems sometimes a minor things, but there are people that for some reason, right, for example, that their kids going to college or whatever, they need to take care of 2 or 3 dogs, for example. They wake up during the night, they go into bed. This can trigger, is strange, but I found this quite in few patients that is associated with the onset of the disease. And it's not that this is the sleep that is creating Parkinson. Probably the brain was already having a process, right? An inflammation or whatever is happening in the brain. But having a secondary, not linked to yourself, sleep problems, give the last hit and make you. So I would suggest to think about what is positive about Parkinson. These other things, somebody ask about it. You can have a silver line. You can say, now I need to sleep. Maybe I will not say on your own, but take care of yourself when you sleep. Take care when you have to have the right food, the exercise. I see it in a positive way. This, I know that it's complicated often, but yeah.
Thank you so much, and thank
Can
you,
I
Gennaro.
quickly say something, Russ? So
Can
about
indeed.
very quickly about this. So there's very little data available on regulation of circadian disturbance in Parkinson's. So I'll be very careful in prescribing anything for this problem. And I think it's more of a lifestyle issue, lifestyle management rather than a medical management.
Okay, thank you so much. And just to bear in mind before we move on to the next question, Parkinson's Concierge hope that you respect our rules when engaging with medical professionals and academia, that we're not able to discuss any specific medications. So I hope that reinforces what you just said there, Amit, because we are in, webinars quite easily led to say one thing or another. But we respect the views of our panel and the questions that are asked from the viewers. We do put like a proviso out there that not everything that's right for one person is right for another. So thank you for that. If we can move on to another one. Before I do that, just to touch on a point that you mentioned, Julia, as we all know, across in the UK, if you turn your TV on, virtually every advertisement break is about a new type of mattress, a new comfortable mattress with so many springs in, memory foam, so on and so forth. Before anyone spends any money on a new mattress, I would genuinely recommend that they try that mattress out, because after all, we spend a lot of time in bed and we're trying to create good bed hygiene, sleep hygiene. So make sure that the bed that you purchase is right for you, not just because you've seen it on TV at one of these sales. So if we can move on to the next question. Wow, I heard this mentioned before. Do circadian rhythm disruptions alter the body's sleep cycle? And if I can address that one firstly to Gennaro, if that's okay.
Sure. As said before, circadian rhythm dysfunction is not the main sleep problem of Parkinson, right? There are others. But as the control of sleep is key. And probably, at least in some of the studies that I've done, I found that in people that report to have sleep problems, there is a reduction of the signal of a specific imaging probe that is called PHNO. It's like is measuring the level of the dopaminergic receptor. So it's an area of the brain linked to the hypothalamus. And this hypothalamus is the master clock of the circadian rhythm. So it's hard to say, what is coming first, right? If it's the sleep, the circadian rhythm that alters the body sleep function, or is the other way around, right? You have a damage of the brain, maybe induced by, a toxin or whatever, and then you develop the circadian dysfunction. So based on the current evidence, yes, circadian rhythm, if it's altered, you will have an issue with sleep, because all circadian rhythm, also temperature, other, but I would be cautious to say this is the cause or the consequence of Parkinson. I don't know if Amit want to.
I completely agree. I think it's as you said, having circadian disturbance will mean that you have sleep problems, but having sleep problems does not necessarily mean that you have a circadian dysfunction. So I think I agree with you entirely on that. I think the question about the circadian things have been looked at very, very carefully. And I think, as I said in my previous comment as well, I think it's better not to go where the data is limited, because it might just be personal opinion. So I strongly believe that there is a lot that can be done in the circadian rhythm field, but at the same time, I don't have the data to support and say that this is the answer for everything. And definitely not for all the sleep problems. So I think it's in itself, one of the key things that hasn't come up in the discussion so far is this problem of excessive daytime sleepiness. So some people with Parkinson's would often experience a disruption of the circadian rhythm in a way that they will be awake all through the night and be sleeping all day. And that is the kind of dysfunction that can be sort of looked at as a circadian disturbance, but not being able to sleep at night or sleeping just 3 hours in 24 hours, that's not a circadian dysfunction, for example, in the clinical sense. So if they've got both the problems where they can't sleep at night and they sleep excessively in the day, that's where the circadian thing is sort of playing a part, because what the biological clock does is, as I think you mentioned previously, that when you turn off the light in response to the dark, the body will create hormones and systems to go to sleep. And when there is light, it will prevent us from going to sleep. So light has a very crucial role to play, but the circadian biological clock based in the hypothalamus is something that we know is affected in Parkinson's, but at the same time, that's not the primary problem. The Parkinson's is a bigger problem, of course, and there are many other factors that influence sleep problems in Parkinson's. I think it's a bit complicated answer, but I hope it sort of lends to the person who asked it.
No, that's very good. Thank you very much. It's very comprehensive and very interesting. I personally used to get very strange sleep cycles, in so much that, like you say, I'd sleep on an evening within for a 24-hour period, I'd get about 3 hours sleep. My body didn't feel tired, and quite often I would carry on working. I was self-employed, so I just used to work. And then possibly about once every week or once every fortnight, I would have an episode where I was physically tired, aching, and exhausted, and I could go to bed at 10 o'clock p.m. one night and sleep right the way through, not hearing my alarms, not needing to get up to do bodily functions, right the way through until 10 o'clock p.m. the following night. So I'd miss a full day. And as we all know, with Parkinson's, your tablets are based over most of the medication is you take it throughout the day. Personally, with his sleeping, I was missing out on a full day's medication. That was quite bizarre. But I must say, since my DBS, all my sleep issues seem to have gone.
Yeah, if I can echo what you say, I found this quite commonly for people that are driven. Some people say Parkinson could be the disease of the leaders, right? People that just go and they can work the whole time and they just sleep 2-3 hours. Unfortunately, it's not good. You know, it's good maybe for your success, but might not be good for your brain. So
Yeah.
I definitely discourage, and I try to, you know, all of us a certain number of hours, right? At least 6 hours would be. It's complicated to say because there are individual differences, but my suggestion is sleep at least 6 hours per night.
I think that the technical term we often use is a crash, what you described, Russ. You just crash if you work too hard.
Yeah. Unfortunately, despite my wanting to get to sleep, it just wasn't possible. So a question to Julia: what time of day should vitamin D be taken?
So again, that goes to depending on how much you're taking. And there's a protocol that is governed by your lab work and in connection with an assessment. So I don't, if you're on a large dose, you might want to break it up. Otherwise, 1 hour to 2 hours before you would go to sleep with oil, with fat, so you can digest it. But there's an entire protocol for that.
Thank you. Julia, while you're there, if I can touch on this one, it's because you mentioned the gut, I feel it's relevant for you. Can diet affect my sleep health?
So, clearly we want to have a healthy diet. There's a lot of talk about ketogenic diet and how that can help some people with neurological issues like Parkinson's. We want to make sure we are giving our body all that it needs in order for our mitochondria to function. When we're talking about sleep, we think about vitamin D, we think about melatonin, but the majority of our melatonin is created from our mitochondria and in our cells. So it all has to kind of fit together. We need to be eating enough fiber that we're getting our gut moving, that we're eliminating our waste. And diet plays a huge role in that. But again, looking at what your individual needs are, what is your diet currently, and what might need to be tweaked in order to make sure you're eliminating regularly, clearing out your bowels, and that you have the proper nutrients that your body needs in order to function appropriately.
Fantastic. Thank you so much. And one thing that we are very aware of is that this audience reaches further afield than just the English-speaking communities. So we have somebody who's asked a question in Italian, and rather than me try to pronounce it and getting it all wrong, just to let that person know that it will be translated and asked of the panel. So thank you for that. Before we go any further, to interrupt the flow of things, it's just a little bit to say an important announcement regarding the content of tonight's webinar with regards to the question being asked. Firstly, we are pleased, we are beyond pleased, we're very privileged, in fact, to have these three distinguished guests on our panel this evening. They've gave up their own personal time to be with us, and for that we genuinely offer them our very much appreciation. We need to point out that we have no particular affiliation to the guests or the organizations that they work for or represent. These people are experts in their field, and like I say, they've gave up their personal time to accept the invitation that we put out for them to be here. One further thing for anyone who's joined before or after I started, just a little script that we have to try and help people. As we know, these are very challenging times for us all, with the continued regional lockdowns and countrywide lockdowns, the restrictions of activities, social distancing rules, etc. It's likely to cause untold effect with anxiety and stress. With more reliance due to the COVID questions and the need to continue support wherever possible, this has a tremendous reliance on the funds available within the charities. As we all know, the lockdown period has significantly affected those of us who had planned fundraising activities, running marathons, cycling events, walking, park runs, etc., etc. Most of the major contributions to charities come from these sponsored events. It's important to remember that this has a huge effect on the charities who rely on these funds to provide the ongoing services for us all. I therefore ask you to kindly consider offering a donation to the EPDA charity, European Parkinson's Disease Association, to enable the charity to continue its offering of these essential services for us all. And the link for their website can be found in the chat. Thank you so much. Moving on to the next question, and I appreciate your time. Can you please explain how the sleep scale works? And that one is asked to Gennaro.
Sure. I mean, first of all, a scale is something we use to have a quantitative measure, right, of a problem. And sleep scale, there are several sleep scales that are currently used. Sleep in the context of Parkinson is considered a non-motor symptoms. So there are scales that are used as a screening in which people are asked to answer yes or no to specific question. The most common one of them is called non-motor symptom questionnaire. And these are patient-reported scales. So the patient answer on his own. There are other scales that are rated by the clinician, asking the question to the patients. And in this case is the doctor that is asking question, and based on the answer, he rate the score. And in both cases, unfortunately, sleep cannot be rated in a very deep way. So I think one of the limitations that we have at the moment with the current scale is that it's not that objective as it could be for example, one of the exams called polysomnography, right? That you are able to measure with several devices how the sleep works in the different stages, if some stage is affected, if you have specific, to have a proper diagnosis. Unfortunately, the scale cannot help us, can be used as a screening. And there are now several digital devices that have been developed that allow us to have a quantitative measure at the bed of the patient, at home, for example. But none of them have reached the level to be used in clinical practice. I don't know if Amit or Julia want to add.
I think, as you were saying, so they're not really used to diagnose sleep disorder or a sleep disturbance. I mean, they point us to that if we use the scale, but they may not help with the diagnosis. So it still relies on polysomnography or sleep studies to get to the diagnosis, depending on the case.
Yeah, Julia, are you okay with that, or should we move on to the next question?
Yeah, no, I think that's great too. And I love the information that you can get from the polysomnography. I wish everybody could have one done, because I feel like it tells us so much about what's going on with a person. Like, if you even think about how many people grind their teeth, go to their dentist and get a night guard made without assessing why that grinding is happening, and the correlation between people who grind and brush their teeth and Parkinson's and Parkinsonian type symptoms is huge. The interconnection there is huge. And yet, if we're just going to our dentist and getting a mouth guard without actually finding out what is happening in our brain to cause that to happen, we are really missing an opportunity to help so many people before their symptoms get to a place where it's devastating for them.
Thank you so much, Julie. That's Julia. That's it's good to see these connections and the early signs. What we need to do is educate the community, the professionals, about looking out for these early signs. So we hope that happens. Another question: do people who fall asleep during the day stand a higher risk of losing their driving license? Dr. Batla?
The simple answer is yes, because that's one of the questions that I often am asked to fill on the DVLA questionnaire. As you know, people with Parkinson's have to notify DVLA about the diagnosis, and the DVLA sends their doctor a form every 3 years to fill in. Nothing to hide in that. One of the questions is your patient likely to have excessive daytime sleepiness? And you have to say yes or no. So that's a question that's part of the questionnaire that's sent to the doctors to answer about Parkinson's. So if I say yes to that, there is quite a likely chance that the doctor who works for the DVLA would prevent them getting a renewal on the license, or they may ask me more questions or ask me to provide more information on what kind of symptoms the person has and what has been done for that. So generally they give us some space to write that. So depending on who's filling in the questionnaire and how well I know the patient, I can either say that they've got excessive daytime sleepiness, and that might mean they lose their license, or I can say they do not have excessive daytime sleepiness. Either way, I can maybe quantify that a bit further or give more information to the DVLA that can allow them to get their license back or not. But the simple answer, as I said, is yes. It's more likely that if you have excessive daytime sleepiness and your doctor picks that up and writes that in the questionnaire that is filled in every 3 years, then your license may not be renewed.
Thanks, Dr. Batla. And quite often, a lot of the medications that the individual's on clearly say that it can cause excessive drowsiness.
Yes, and exactly. So one of the columns in the form is about the medication as well. So the DVLA knows what you're on. They know what can make you drowsy. And if there was something, they ask you the reason for why this person is on this medication. So if you are getting something to keep you awake, for example, or something that can put you to sleep, they will get that information. And as I said, the specific question is about excessive daytime sleepiness.
Thank you. Gennaro, you took your mute off. Would you like to come in at this stage?
No, I mean, I totally agree. And I think one thing we need to be careful is to understand that if the excessive daytime sleepiness is primary or secondary, and maybe adjust the medication accordingly in order to reduce the possibility of the patient to either lose the license. Because if if you think the consequences, right? Losing the license, you might be more at home, you get more isolated, and you create a cycle that make the patient to progress faster. We found in several studies that excess daytime sleepiness is associated to fast progression. I also found a correlation with the damage of the area of the brain called caudate. But I think sometimes this could be a mix of factors. Excess daytime sleepiness is not a disease. It's the consequences of several things happening in the brain, unfortunately.
Thank you so much. And just for the benefit of anyone watching, we do understand that there's a lot of questions coming in on the chat. We are trying to keep tonight's session more to deal with sleep issues. So I do appreciate the questions that you're asking, one of which is more of an individual basis. So we would recommend speaking to your neurologist or your healthcare expert. There's a statement more than a question come in from our good friend in Italy, I believe. He's basically said, in India, I discovered how important to have dinner very early and go to bed at 9 o'clock after an oil head and foot massage to give a message to our body to switch off our brain and start to produce natural dopamine by regenerating sleep. Thank you, Massey. That's I'm sure people would love that, getting a massage every night before we went to sleep. Right. There's another one here.
I repurposed this. I read this research, but it did not work. At least.
Right. There's another question coming here. What kind of mattress is recommended? And if I can just join in there and say, please go to a bed specialist, try out the mattress, lie on it. You know, they've got these protective covers on in the shops. So try it, make sure it's right for you. Failing that, there's experts, and tonight's sponsor is a company called Opera Health, and they actually do a service where they're a professional company. So, you know, they would make sure that you had the right kind of mattress, the right kind of accessibility bed, if that's needed at this stage. We spend a lot of time in bed, so it's worth investing in a high quality mattress to allow you to get some good sleep as well. So thank you very much for the questions that are coming in on the chat box. Like I say, there's a few that aren't really relevant to tonight, but we will answer you after the session and give you some advice. So we've got another question here. My husband has recently started hallucinating when he's trying to fall asleep, which are distressing both him and me. Julia, you're on my main screen, so would you like to address that one?
I think that I would leave to the neurologist and the sleep doctor to answer that question, actually.
Thank you.
Mm-hmm.
So I think I'll take that. That's a common thing. So hallucinations in Parkinson's, most commonly they are drug-induced, so they are related to the dopamine, and they're common. It's one of the side effects with medication. So first thing to do would be to optimize the timing of the medication and making sure that the hallucinations are not related to excessive dopamine levels. It's always, it's a clinical issue. So again, I will point to discuss with the clinician that you're under, whoever that is. And I would say that it's not really considered as a sleep problem. Hallucinations can happen more commonly in the evenings anyway with Parkinson's and treatment. So most of the medication-induced side effects with hallucinations happen in the evenings and just before bed. So that's not unusual. So maybe you need to optimize the medication and you should speak to your doctor.
Thank you. Gennaro, do you have anything to say on that question about hallucinations?
I mean, I think this is a quite complex problem. I think, I totally agree with Amit, and I don't have anything else to add.
That's fantastic. Thank you. Thank you anyway. The reason I asked is everyone's got their own opinion and specialist area regarding sleep tonight. So we wanted to make sure that everyone gets the opportunity to answer if they may. Is having a good routine a major part of improving your sleep health? Yes. Straightforward, yes. Why am I suddenly experiencing sleep issues where I can't get to sleep? This has just happened after 16 years of Parkinson's.
So again, as I said, so it depends on what time of Parkinson's we're looking at. Over a period of the whole of the Parkinson's, like we just discussed, 98% will have some or the other problems. It could be that you're having problems at a certain sort of stage of Parkinson's 16 years down the line, also because of some changes in medication. So it's always worth revisiting whether you've been prescribed something that might be making you drowsy and things like that. Mostly, as I said, it can happen, so I won't be too surprised if it has happened because of Parkinson's and just as part of the Parkinson's picture, non-motor symptoms, but it could be due to medication or some other factors. The other thing that we haven't covered so far, which I think is very important because we've got Julia on the panel, is something called sleep apnea syndrome. Now, sleep apnea is a condition where people's airway is obstructed when they go to sleep and they can't breathe very well. They will often choke or get up and sort of gasp for breath. They would often not know about it because they would be asleep, and it's usually the partners who notice that the person was sort of short of breath and sort of making very strange noises at night, for example, and not being able to breathe very well. And something that can start later in life along with the Parkinson's is sleep apnea, and then again that's something linked to the duration of Parkinson's, or sometimes it might come later. So these are the few things that one should keep in mind.
I would like to also add, if I can, it would depend on if the patient is the patient male or female, because sometimes a woman, as she starts to go through the change of life and go through menopause, might start to have some hormonal issues compounding her Parkinson's symptoms that kind of raises her risk factor of all these sleep things that Amit has mentioned.
Thank you, Julia. That's thank you, Dr. Batla, as well. Very good topic, and the sleep apnea side of things was interesting to add to the question. The question that's come in: why do I get leg cramps, painful leg cramps? They're so painful they wake me up at night, and they've got to wake up their husband to get her out of bed. And they've just suddenly come on, I believe. And if I can ask that, Gennaro, you're on my screen, so.
Sure. I mean, there are several reasons. Leg cramps is not, again, it's important to identify what is the cause. In my case, in several occasions, I found that magnesium could help. You know, this is something, I mean, again, we don't want to suggest a prescription because you need to go to your doctor, but I found that in several cases, adding magnesium to the diet, it could be quite useful. And of course, it needs to be identified the root cause. I don't think there is a biological, as far as I know, signature of why you have cramps, but I maybe my other colleagues can have.
Yeah, so I agree. I think cramps can be due to many causes, but while we are on that topic, I'll try and, because I'm trying to cover as many things that we haven't discussed so far, and I know we're almost an hour in. One of the symptoms that people often describe is something called restless legs syndrome. Now, this is something that's very common with Parkinson's and even without. So not everybody who has restless leg syndrome has Parkinson's, but many people with Parkinson's will have restless leg syndrome. This is something where you will have an urge to move the legs just before bedtime. So when you're lying in the bed and you're trying to be still and go to sleep, your legs will keep you awake and they won't be able to find a comfortable position, if I might say. And no matter how many mattresses you try, I had one patient who tried 7 mattresses and had to return all of them. The restless legs won't go. And no matter how much you try to sort of find a comfortable position, that's why it's called restless leg syndrome. One thing that comes with the restless leg syndrome is something called periodic leg movements of sleep, meaning they would have intermittent jerks or movements when they are asleep. Cramps are also very commonly associated with restless leg syndrome and even without. So cramps can happen with Parkinson's. They generally in clinical experience, I'm just talking from mine and the few papers that I've read about it, it might reflect a lack of dopamine as well. So for example, you run out of your dose and at night you've not taken any dose for medication for a long time. So both with restless leg syndrome and with cramps, sometimes the nighttime dose is very, very useful. So again, discuss with your professional if that might help. But again, the nutritional factors, like Gennaro was saying, there may be dehydration very commonly, especially people who don't drink in the afternoon and evening because they don't want to get up in night to go to the toilet. They dehydrate themselves at night. They don't have enough water, and that might lead to other problems as well. So I think there can be many factors, but just wanted to cover the restless leg syndrome and periodic leg movements, which are again common things.
Thank you, Dr. Batla. That's very interesting. We are coming up to the top of the hour, and we've taken up a lot of time of our esteemed guests this evening. So that just leaves me to once again say, if you can, follow the link to the EPDA, which is the European Parkinson's Disease Association. They're our charity of the month. And also, if you are in the market for looking for a new bed or a new mattress, try as many as you can, but also try Opera Health, who are the trusted experts in care for their beds and mattresses. And I know, Dr. Batla, you said that one of your patients went through 7 that they had to return. That's
interestingly, most mattress companies these days allow you to do that. You can sleep on them and then return them if it doesn't agree with you. And as I said, this patient had particularly tried 7.
gaming. Memorize so they remember where they came from. Oh well, on to the next one. Well, it's been an absolute honor and privilege to welcome Dr. Batla, Gennaro, and Julia to tonight's webinar. And may you go from strength to strength. And on behalf of the people in the Parkinson's community, thank you so much for the dedication, the work that you put in, and the knowledge that you have that's helping a lot of people with Parkinson's. Thank you.
Thank you for the work you're doing. Thank you.
Thank you. Julia was saying you're doing amazing work and keep it up.
Thank you so much. And for anyone who hasn't had any questions answered, we will be getting around to making sure you get an answer for those. I'm not sure if Annie Rudd's about.